Good afternoon, everyone, and thank you for joining Anemia Chat, Understanding Anemia of CKD. My name is Molly Alawade, and I'm the Director of Education here at the American Kidney Fund. There are so many people living with late-stage kidney disease and on dialysis who have anemia, and so many more who don't know about it. So today, we're going to talk about this common complication of kidney disease and how you can manage it. Before we get started, I'd like to give a special thank you to AstraZeneca for their sponsorship of this activity. I would also like to welcome our anemia expert for today, who will be helping us to understand anemia of CKD and answer your questions. Dr. Jay Wish is a professor of clinical medicine at Indiana University School of Medicine in Indianapolis and Chief Medical Officer of Dialysis Services at Indiana University Health. Hi, Dr. Wish. Thank you for joining us today.
It's a pleasure to be here, Molly.
Great. Well, before we continue, let's go through some housekeeping items. As a reminder, this event is being simulcasted on Zoom webinar and Facebook Live. If you are watching live, please join the conversation. Let us know you're here in the comments section and type any questions you have using the Q&A feature on Zoom or in the comments section on Facebook. We'll try to get to as many questions as we can during the Q&A session. So let's jump into the conversation, Dr. Wish. And let's get started with a basic background question. What does it mean when someone has anemia?
Well, Molly, anemia happens when there are not enough red blood cells in your body. Red blood cells carry oxygen from the lungs through your bloodstream and deliver that oxygen to your tissues, giving you energy and helping your heart, your muscles, your brain, and other organs work properly. If you have a decreased number of red blood cells, which is what anemia is, this results in less oxygen being delivered to these organs, and most of the symptoms that patients with anemia feel are a result of this decreased oxygen delivery.
Oh, that's great to know. And that explains why a lot of people with anemia talk about having low energy. So what are some of the other symptoms of anemia that people may have?
Well, there are a number of symptoms, and it's important to remember that a lot of these symptoms that I'll be talking about aren't unique to anemia. Chronic kidney disease, diabetes, heart failure, and other conditions that patients with chronic kidney disease often have may also produce similar symptoms. So it can be very difficult for you or your physician to differentiate whether or not these symptoms are due to the anemia or perhaps due to other conditions which may coexist. So sometimes the only way to figure this out is to treat the anemia, see whether or not the symptoms improve. If they do, one can assume that the symptoms were related to anemia. And if they don't improve, then it's back to the drawing board trying to figure out what might be causing the symptoms and addressing those issues. The most common symptoms of anemia, as we talked about, are weakness, fatigue, low energy level. Many patients get short of breath, especially with exercise. They may feel cold all the time. They may feel dizzy or lightheaded, or inability to concentrate, inability to keep focus on a task, often falling asleep even during less stressful periods while you're reading or working on your computer, et cetera. Many patients, especially if they have underlying coronary artery disease, may develop chest pain, especially with exercise. It's very typical that patients who are more severely anemic have pale skin, because a lot of the redness that you see in normal complexions is due to the red cells being present in the skin. You may develop a fast or an irregular heartbeat. Some patients will complain of headaches or difficulty sleeping. Difficulty sleeping includes the hard to fall asleep at night, frequent waking at night, and as I talked about before, inability to stay awake during the day with frequent napping or just falling asleep when you're not stimulated. There's some trouble concentrating, as I said. It's unusual, but some patients will complain of nausea, trouble breathing, we talked about, and muscle pains or cramps in the muscles can often occur, even at rest, but often during exercise.
Wow, those are a lot of symptoms to keep track of. And like you said, I mean, there are many other conditions with similar symptoms, so it could be really hard to distinguish anemia from other conditions. So I want to pause real quick, and if anyone is just tuning in, we are having an anemia chat with Dr. Jay Wish. If you have any questions for Dr. Wish, please put them in the Q&A box or in the Facebook comment box. So let's get back to the conversation. So there are so many people on dialysis who feel tired or weak. So how does someone know if they have anemia for sure?
Well, this just doesn't apply to patients who are on dialysis. Patients at any stage of chronic kidney disease, even the early stages like stage 2 or 3, can develop anemia, and this can produce symptoms. So the major way that we diagnose anemia is with a blood test called the hemoglobin level. And it's an indirect reflection of how many red blood cells are in the circulation. Hemoglobin is the molecule inside the red blood cells that actually carries the oxygen from the lungs to the tissue. So the hemoglobin level is really the best indicator of whether or not there's adequate oxygen delivery to the tissue based on whether or not there's adequate numbers of red blood cells. If you have fewer red blood cells, it means there's less hemoglobin, so the hemoglobin level will be lower than normal. The normal hemoglobin level for men is 14 to 17, and the normal hemoglobin for women is about 12 to 15. And I should point out that men generally have higher hemoglobin levels than women, number one, because male sex hormones, androgens, stimulate the bone marrow to make more red blood cells as opposed to the female sex hormones, and because women who are menstruating will lose blood, they'll lose hemoglobin during their menstrual periods, and that will decrease the hemoglobin level as a result. So in men, as I said, anemia is generally defined as being lower than the lower limit of normal, which is about 13. And in women, anemia is defined as hemoglobin lower than the lower limit of normal, which is less than 12.
Okay, that is great information. So basically, in order to know if you have anemia, you have to get your hemoglobin tested to see if it might be below the normal level. All right. So then why is anemia so common in people with kidney disease?
And as I mentioned, it is very common at all stages of chronic kidney disease, but becomes much more common as you get to the more advanced stages. It was typically thought that patients in the early stages of chronic kidney disease rarely had anemia as a result of their kidney disease. But now we realize that it's actually more prevalent than was originally thought. And even patients with stage 2 chronic kidney disease have been shown to have about a 5 or 6% incidence of anemia. Once you get to stage 3, it's about 15% of patients will have anemia. And when you get to the later stages, 4 and 5, almost 60% have anemia. And then when you get on dialysis, especially hemodialysis, about 90%, 9 out of 10 patients will have anemia. So it becomes extremely prevalent in those later stages. The reasons that patients get anemia with chronic kidney disease are more complex than what was originally thought. It was originally thought that because the kidney is the major source of a hormone called erythropoietin, as the kidneys failed, they produced less erythropoietin. And that was thought to be the major reason why less erythropoietin means less stimulation of the bone marrow to make red blood cells. And as a result, you get anemic. However, now we understand there's a lot of other compounding factors that contribute to anemia in patients with chronic kidney disease. The most important of which is probably iron deficiency. Iron is a major building block for hemoglobin. Iron is what makes hemoglobin red. That makes red blood cells red. You know that iron is red because it rusts and it turns red. So iron is extremely important as a building block for hemoglobin. And patients with chronic kidney disease are very often iron deficient. It's estimated that for patients who are not on dialysis, 50% of those who are anemic probably have some degree of iron deficiency. And for patients who are on dialysis, about 80% of those who are anemic have some degree of iron deficiency. So iron deficiency, because iron is an essential component of hemoglobin, can be a very important contributing factor to the anemia. Where do you get iron? You get it from your diet. So patients with more advanced chronic kidney disease often don't eat iron-rich foods, One, because they just don't have an appetite for them. And number two, because some of the dietary restrictions that they get limit the amount of iron containing foods. So iron supplementation is often part of how we approach anemia in patients with chronic kidney disease.
That is really important information and a perfect transition to our next question, which is about the management of anemia. So can you talk about what people with anemia can do to manage symptoms? And is there anything new in anemia that patients need to know about?
Absolutely. Well, as I mentioned, iron deficiency contributes to anemia in about half the patients. And once you're on dialysis, 80%. So the first thing we do in an anemic chronic kidney disease patient is to screen for iron deficiency. And there's two blood tests that we look at, and they have a little different meaning, but in combination, we can get a pretty good picture of whether or not the patient is iron deficient. If you're a non-dialysis patient, or if you're a home dialysis patient, then the easiest, most patient-friendly way to treat the iron deficiency is to give an oral iron supplement, because it doesn't require any trips to a healthcare facility to get the other form of iron, which is intravenous. The problem is that many patients just don't respond to oral iron supplements. Either they get side effects that can cause upset stomach and constipation, et cetera, that causes an inability to adhere to the prescribed regimen, or the iron deficiency is just too great to be replaced with oral iron, because the absorption of oral iron tends to decrease in the setting of chronic kidney disease. So again, if you're not an in-center hemodialysis patient and you to oral iron therapy, then the next step, if you're iron deficient, would be to administer a intravenous form of iron. Now, I should point out that almost all dialysis patients, about 80% of in-center hemodialysis patients, are getting intravenous iron. It's basically administered through the dialysis circuit because of the high prevalence of iron deficiency in that population. But for a non-dialysis patient or a home dialysis patient to get intravenous iron, they have to come into an infusion center and get the IV iron. Once the iron deficiency is treated, or if the patient is not iron deficient, then the next step is to treat by replacing that erythropoietin hormone that I mentioned in the last section. As I mentioned, the kidneys are responsible for making this hormone, erythropoietin, also known as EPO. And in the setting of chronic kidney disease, the ability of the kidneys to make this EPO goes down, and this decreases the red cell production by the bone marrow. So since 1989, we've actually had a pharmacologic version of this exact same hormone that can be administered to the patients who have anemia. And again, if you're an in-center hemodialysis patient, it's probably intravenously administered through your dialysis circuit. But if you're not an in-center dialysis patient, you're CKD, not on dialysis, or your home dialysis, then it has to be given as an injection, and it's generally given subcutaneously. And depending upon various factors, you can self-administer at home, or you may have to come to a center to get the erythropoietin shots. The last resort for the treatment of anemia, if the iron and the erythropoietin aren't working, or there's some additional blood loss that occurs because of gastrointestinal bleeding or some other surgical complication, et cetera, the last resort would be blood transfusions. So we do use blood transfusions in patients who have severe anemia, generally hemoglobin less than 7, and obviously giving the red blood cells brings the hemoglobin level up to a point where it puts less stress on the cardiovascular system and makes the patient feel better. Now, there is a new class of anemia treatment agents, which are not yet approved, but I want to mention just to kind of be complete. And it's expected that the first of these will be approved later this year. They're called hypoxia-inducible factor, and we don't always say that, all those words. We abbreviated HIF. Prolyl hydroxylase inhibitors, and again, we abbreviate that as PHIs. So these HIF PHIs, also known as HIF stabilizers, actually work by stimulating your kidneys, even if you have kidney disease, to make more erythropoietin. And it's been shown that they even work in patients who are on dialysis, where it was previously thought that their kidneys were pretty much shot and couldn't make EPO at all. But it's now been shown that this class of drugs can basically squeeze blood out of a stone, to make an analogy. They can actually make kidneys in patients on dialysis and those that aren't on dialysis make more EPO. And again, this stimulates the bone marrow to more red blood cells. One of the appealing characteristics of this new class of drugs, unlike the EPO injections that I talked about, is that they're orally administered. So again, for patients who are not on dialysis or on home dialysis that have to get the EPO shots subcutaneously rather than intravenously through their dialysis circuit, the idea of an orally administered drug where you don't have to come into a center and you can just basically swallow a pill, 3 times a week or daily, depending upon the medication. Obviously, that's a much more patient-friendly approach.
Wow, that is an exciting update. So it sounds like we've got those 3 treatments that you talked about: EPO therapy, iron therapy, as well as red blood cell transfusions, and this new treatment, HIF stabilizers. So that's really great news for people living with anemia of CKD. So I want to jump in and say, if you're just joining us, welcome. We are having Anemia Chat this afternoon with Dr. Jay Wish, talking about anemia of CKD. If you haven't already, please type your questions into the Q&A box on Zoom or into the comment box on Facebook. All right. Well, this has been a really engaging conversation so far, and we've got some questions coming in. So let me go into the chat box and pull some of them for you here, Dr. Wish. So someone has asked, I have been told that some anemia is relatively normal for older people. Is this true? And what type of iron is most beneficial to increase the red blood cell count?
Okay, well, it is correct that often red blood cell counts do go down with aging, but anything under 13 for men and 12 for women in terms of the hemoglobin level is considered anemic by the World Health Organization. They set these standards irrespective of your age. So even though there tends to be a trend downward, once you get below those particular limits, you are considered anemic. It's very interesting that you brought that up, because there's been studies among patients with chronic kidney disease that show that the incidence of anemia among patients who are greater than 65 years old at every stage of chronic kidney disease is significantly greater than those with the same level of chronic kidney disease or the same stage if they're less than 65 years old. So I think it's a good point that age is clearly a risk factor for anemia. Now, as far as what iron is best, that's obviously a very open question, and there's a lot of considerations that go into that. Again, if you're not an in-center dialysis patient, you're CKD or perhaps a home dialysis patient, then it's possible that oral iron might work for you. And again, because that's a very easy thing to take at home, you take a couple pills a day and you don't have to come anywhere to get a shot. That is usually what we try first, unless, number one, the iron deficiency is so severe that we're very pessimistic that the oral iron will work. Because as I said before, oral iron absorption tends to be decreased in the setting of chronic kidney disease. Or you have problems with oral iron. And many of our patients have been on oral iron supplements before. They tell us that, oh, it upsets my stomach, it makes me constipated, it's more pills, I'm already taking a zillion pills, I really don't want to take any more. And in that situation, we will generally recommend an intravenous iron infusion. Now, as I said before, patients who are on chronic hemodialysis in center will generally get regular doses of intravenous iron during their dialysis treatment to keep their iron levels normal, so they don't really have to worry about iron.
Thank you for that explanation. That's really good to know. So someone else has asked, let's see. How do I know if I have anemia caused by iron deficiency or EPO deficiency?
Very good question. So as I said before, the first thing that we do when we diagnose a patient with anemia is to get iron levels. And if the iron levels are low, that tells us that at least iron deficiency is present. Now, EPO deficiency may be present as well, But first, we have to correct the iron deficiency to see whether or not that does the job. So we diagnose the iron deficiency. If it's present, again, we can treat either with oral or IV iron, depending upon the situation. If we normalize the iron levels in the blood, and again, this requires repeated determinations of the iron levels in the blood to see how we're doing in terms of the effectiveness of the therapy, and the iron levels are now normal, but you're still anemic, then basically make a diagnosis of EPO deficiency by what we call exclusion. Okay, it means we don't check EPO levels. We basically assume that a patient with chronic kidney disease who's not iron deficient, who has no other obvious reason to be anemic, and who's still anemic is probably EPO deficient. And in that situation, we may consider treatment with EPO. Now, I should point out that we generally don't use EPO unless the hemoglobin is less than 10. And you heard me saying, well, but you're anemic when your hemoglobin is less than 12. What do I do between 12 and 10? And the answer is we replace the iron, but we're really not allowed by the FDA and also by prescription drug plans to prescribe EPO unless the hemoglobin is less than 10.
All right, that's important information. Thank you. One person asked, are some kidney patients more likely than others to get anemia?
Great question. And there are a number of risk factors that seem to contribute to anemia. The first is the stage of chronic kidney disease. As I said before, the more advanced the stage, the more highly prevalent anemia will be. From maybe 6% at stage 2, 15% at stage 3, 50% or more at stages 4 and 5, 90% once you're on dialysis. So that is probably the major determinant. Second determinant, which I've already addressed, is age. The older you are at any given stage of chronic kidney disease, the more likely you are to be anemic. And then there's the issue of inflammation. And I kind of touched on that, but I think it's worth talking about now. Any inflammatory condition, and there are very many of them which patients with chronic kidney disease can get, can also contribute to anemia because inflammation alters your ability to send iron to the bone marrow where it's needed to build new red blood cells and to be incorporated into hemoglobin. So inflammatory conditions such as diabetes, it's an inflammatory condition. Heart failure, it's an inflammatory condition. And certainly if you have something like lupus, which we know is primarily an inflammatory disease, all of those things will contribute to make it more likely that you'll get anemic at any given kidney disease stage and age.
That's a great explanation. Thank you. So someone else says, my doctor advised me not to eat red meat. What types of food are iron rich? He advised broccoli, spinach, and liver as examples.
Those are good examples of iron-rich foods. Actually, of everything, liver is probably the most iron-rich if you can eat it, because a lot of people don't like liver, myself included. I'm not sure why your doctor advised you not to eat red meat, because red meat actually is a great source of iron. It's probably one of the best sources of iron. But as you pointed out, green leafy vegetables such as broccoli, asparagus, spinach are relatively rich in iron. I think you need to talk to your doctor if you are in fact iron deficient, why there is a restriction on your ability to eat red meat. I think in that situation, the benefits of red meat may outweigh any risks that your doctor is thinking of in terms of prescribing a restriction.
Great. All right. So someone asked, does anemia of CKD improve after transplantation?
Yes, it does, because your kidney function improves. That's the whole idea of the transplantation. So giving a kidney transplant gets you from stage 5 chronic kidney disease or dialysis, where, as I said, the incidence of anemia is 50 to 90%, then probably down to stage 2 or stage 3, where the incidence of anemia is maybe 6 to 15%. So it may not eliminate the anemia altogether, but it's certainly going to make the anemia less severe, and it gives you a better chance of not being anemic at all.
Well, that is great to know. And I just want to jump in and remind everyone watching, if you have any questions, please submit them in the Q&A box on Zoom or in the comment section on Facebook. All right, we've still got quite a few questions here, Dr. Wish. This is a great conversation this afternoon. So someone asked, how can I deal with fatigue? I know we talked about that as one of the main symptoms here. So someone wants to know how they can better deal with it.
Absolutely. Dealing with fatigue can be very tough. And I sympathize to all of you who are fighting fatigue, because I know how tough it can be, you know, having had some illnesses myself where I was very, very tired and just couldn't seem to shake this feeling that I was just kind of stuck in molasses. Other than treating the anemia, if it is present, certainly you want to make sure that you're getting adequate sleep and that you have good sleep hygiene. So first of all, be sure you're trying to get your 7 to 8 hours of relatively uninterrupted sleep per night. Review your medication list with your physician or provider and see if you can decrease or even eliminate some medications that cause fatigue. And there's a lot of medications that patients with chronic kidney disease, diabetes, heart failure, hypertension take that can contribute to the fatigue. So you need to inventory every single medication on that list with your physician. And if your physician is concerned that it may be contributing to your fatigue, see if you can substitute an alternate medication for that particular issue that doesn't cause as much fatigue. And then finally, if fatigue persists despite all of these things and your partner tells you that you're a snorer, then there's a possibility that you have obstructive sleep apnea, which is extremely common in patients with diabetes, hypertension, chronic kidney disease, being overweight, etc. And if that is the case and you're a snorer, then you might want to talk to your physician about getting a sleep study to see if you have sleep apnea. And if you do have sleep apnea, you may benefit from CPAP, continuous positive airway pressure, which will prevent your oxygen level from going down during the night, because low oxygen level during the night can be a significant contributor to daytime sleepiness and fatigue.
Wow, that is great advice. So someone else asked, does B12 or vitamin D levels affect anemia? Oh, Dr. Wish, are you still with us?
I'm there. I had a
there
little
we are.
in Zoom. Sorry about that.
No problem. Let me ask the question again. Somebody asked, does vitamin B12 or vitamin D, do either of those affect anemia?
Very good question. Vitamin B12 and folic acid, which is another B vitamin, also are very important contributors to red blood cell production. So part of our guidance that has come from a review of the literature and kind of common clinical practice is that if a patient is anemic and they don't respond to iron or there's no iron deficiency, then one of the things that we will often look for is vitamin B12 and folic acid deficiency. So if your anemia is not responding to treatment, you may want to ask your doctor to check for these levels. And if you're deficient with either of these B vitamins, then supplements or changing to a diet that's richer in these substances may help. Vitamin D, of course, is important in bone and mineral metabolism in patients with chronic kidney disease. Many patients with chronic kidney disease are vitamin D deficient, but vitamin D deficiency itself does not contribute to anemia. But since we're on the subject of bone and mineral metabolism, if you happen to have secondary hyperparathyroidism, which is another bone and mineral complication of chronic kidney disease, then that can contribute to anemia. So it's very important, again, if it's not clear what's going on with the anemia, that the easy things have been checked and have been addressed, then one of the things that your physician probably should be looking at is your parathyroid hormone level and treating secondary hyperparathyroidism with vitamin D supplements, which decrease the parathyroid hormone levels, but don't directly affect the anemia.
Wow, thank you for making that connection. That is so good to know. Someone else asked, is there a a point where you are taking too much iron and you should stop?
Very good question. It's almost impossible to get iron overloaded from oral iron supplementation if you're an adult. Now, kids can't overdose on iron, and that's why oral iron supplements should always be kept out of the reach of children, because kids do not have the gatekeeper function of their gastrointestinal tract to only absorb the iron you need and not absorb the iron that you don't need. So because kids are growing, their gastrointestinal tract is much more open to iron absorption to support muscle growth and all the other things that need iron when you're growing. But as you're an adult, that gatekeeper effect of the gastrointestinal tract to prevent excessive of oral iron absorption kicks in. So it's almost impossible to overdose on oral iron. On the other hand, if you're getting intravenous iron, as many dialysis patients do and many non-dialysis patients do, then it is possible, since you're bypassing the gastrointestinal tract, to get too much iron. So your doctor is probably monitoring your iron level, is either decreasing or stopping the IV iron supplements when your iron level gets too high, but it is something that needs to be looked at.
All right, well, thanks for breaking that down. So earlier, Dr. Wish, you talked about inflammatory conditions. So someone submitted a follow-up question and asked, is there a correlation between pulmonary hypertension, chronic kidney disease, and anemia? And is pulmonary hypertension considered an inflammatory condition?
Well, pulmonary hypertension can occur for a variety of reasons, some of which are inflammatory and some of which are not. Hypertension itself can be an inflammatory disease. It's been shown that people who have high blood pressure have higher levels of a variety of inflammatory mediators in their blood. And to a certain extent, it may be it may be true for patients with pulmonary hypertension. There is a connection between chronic kidney disease and pulmonary hypertension, just like there is a connection between chronic kidney disease and systemic hypertension. And the reason is that chronic kidney disease fills the tank, okay? Hold on to more salt and water because your kidneys aren't as effective in getting rid of dietary sodium and water. And as the tank gets fuller, the pressure in the system goes up. One of the ways that the system protects the organs from that higher pressure is to constrict the arteries and trying to not allow that transmission of pressure to the delicate capillaries that feed the organs and where the red blood cells basically unload their oxygen to the tissues. So although pulmonary hypertension can be due to other things, very frequently in patients with chronic kidney disease, it's due to the chronic fluid overload. So in that case, it would not be an inflammatory condition because it's due to primarily a full tank. But in certain other instances, it can be. The problem can be independent of the high level of salt and water in the system. In that case, it could be inflammatory. So the bottom line here, however, is that if you have lung disease, whether it's due to pulmonary hypertension or other things, systemic diseases, emphysema, chronic bronchitis, etc., the malfunction of the lung can, in fact, cause decreased oxygenation of the red blood cells. So even though you may have the normal amount of red blood cells, they're not carrying the normal amount of oxygen, and that can sometimes give you similar symptoms to anemia.
Yeah, that's really good to know. Thank you. Let's see, following up on our discussion earlier about diet and anemia, somebody asked, let's see, many green leafy vegetables are higher in iron, but they're also high in potassium. And I am on a potassium restricted diet. And some of my favorites like spinach and broccoli are out for me. So are there any particularly high iron veggies that are also moderate or low in potassium?
I'm not a dietitian, so I can't tell you what the potassium and iron content is for every vegetable. My understanding is the less leafy it is, the less potassium it is. So it's things that are more stalky, like broccoli and asparagus. Again, my understanding may not be absolutely correct, but this is, what I tell my patients. based on my limited understanding of the content of these foods. And I always encourage them to follow up with the dietitian that the leafy stuff tends to give you relatively more potassium and less iron, and the stalky stuff like the broccoli and the asparagus tends to give you a little more iron and a little less potassium. But again, I would recommend that you discuss each of these foods with your dietitian to be sure.
That's great advice. And if anyone wants any additional information about kidney-friendly diet, you can visit kitchen.kidneyfund.org, which is AKF's Kidney Kitchen website. So coming back into the questions, somebody else asked about exercise. Specifically, will exercising, such as walking for at least 30 minutes a day, help with managing anemia?
It won't raise your hemoglobin, but it may make you feel less tired. So if the goal is to decrease the symptoms, which of course it is, I mean, treating the anemia is a means to the end being the patient feeling better, having a better quality of life, being able to do more things, being able to interact with their family, their friends, work more effectively, concentrate more effectively. Then exercise is going to help all of those things, even though it doesn't actually raise the hemoglobin level.
That's good to know. And let's see, I think coming to the end here, let's make this our last question for the day. What question should I ask my nephrologist at my next appointment if I want to know more about anemia?
Well, the first question is, am I anemic? What is my hemoglobin level? If I'm a woman, is it less than 12? If I'm a man, it's less than 13. If I am anemic, has my physician first looked at my iron level, determined that my iron level is adequate? If it's not adequate, why haven't I been prescribed an iron supplement? Has my physician considered the fact that I might have another vitamin deficiency and screen for that, the two being B12 and folate? And, if I'm sufficiently anemic, my iron is repleted, my hemoglobin is still less than 10, am I a candidate for EPO therapy? And again, in dialysis, it's almost universal. 90% of patients get EPO, they get IV iron. This usually is not an issue in terms of the physician not keeping an eye on these things, because it's pretty much part of the dialysis unit protocols. But if you're a non-dialysis CKD patient, the physicians tend to be much more, shall we say, non-protocol driven, and it's really up to them and the patient to kind of keep on them to make sure that these things are being screened for on a regular basis. What the guidelines recommend is that anybody with stage 3 CKD or greater, stages 3, 4, or 5, not on dialysis, be screened for anemia at least yearly. If you're not anemic, then you don't need another screen for another year. But if you are anemic, then the next trigger would be what is causing the anemia, rule out iron deficiency, rule out B12 and folate deficiency, treat the iron deficiency if it's present. If you're treating the anemia, then you want to be sure that you're doing an effective job. So you want to follow up on the hemoglobin level, not yearly, but maybe in 3 months or 4 months to see whether or not your intervention is having the desired effect.
Well, those are some great pointers for patients to bring to their next nephrologist appointment. Thank you, Dr. Wish. So thank you for answering all of those great audience questions. That was a lot of really important information, and we've really enjoyed having you with us today to share your expertise. For those of you who are looking to learn more, there are resources available to you at kidneyfund.org. So Dr. Wish, do you want to take us through some final takeaways?
Yes, I would be happy to. And it's been a pleasure joining this webinar today. The take-home lessons that hopefully all of you will remember and perhaps discuss with your physician at your next appointment is the fact that anemia is very common in patients with chronic kidney disease. Its frequency and severity do increase with the stage of chronic kidney disease from 6% at stage 2, 15% stage 3, 50% stages 4 and 5, 90% on dialysis. Anemia causes many symptoms, but most, if not all of these symptoms can be due to other things. So it's very important that you work with your doctor to diagnose and treat the anemia to see whether or not the symptoms improve. If they do, great. If they don't, then consider the possibility that some of those symptoms might be due to other things and discuss what those possibilities are with your physician or provider. The cause of anemia in most patients with chronic kidney disease is iron deficiency and deficiency of the hormone erythropoietin, or EPO. Some patients just have the EPO deficiency. Some patients have just the iron deficiency. Some patients have both. And it's up to your physician and you to figure this out by getting iron studies, treating iron deficiency if present. And if that doesn't do the job and your hemoglobin is less than 10, then treatment with the pharmacologic form of erythropoietin may be appropriate. So there may be side effects to these treatments, and no drug is completely without side effects. For patients who receive oral iron, many will complain of gastric distress, constipation, etc. Intravenous iron can be associated with allergic reactions. Erythropoietin usually doesn't have any acute side effects that the patient notices right away, but long-term erythropoietin use has been associated with side effects, so you definitely want to discuss these with your provider. And as we mentioned, there is one exciting new category of anemia treatment drugs, the HIF-PHIs or HIF stabilizers, that stimulate your kidneys even if you're on dialysis to make erythropoietin, and may hopefully, at least in my mind, substitute for erythropoietin therapy in patients who are on home dialysis and patients who are on non-dialysis CKD, who would otherwise have to get injections and go to a healthcare provider to get those injections. So this availability of an oral replacement for erythropoietin shots, at least to me, is very exciting, and I think that the patients will definitely welcome that.
All right. Well, thank you so much, Dr. Wish, for going through those key takeaway messages and for spending time with us this afternoon to talk about anemia of CKD. We hope that this was helpful, and we look forward to continuing this discussion in the future. AKF is creating additional resources on managing anemia, which will be available in the coming months. Make sure to like us on Facebook and to send us your email through kidneyfund.org to be one of the first to know about those new resources. Before we close, I'd like to thank our sponsor, AstraZeneca, once again for making today's activity possible. And finally, thank you to everyone at home for joining in with us on Zoom or Facebook. If you are on Zoom, we ask that you please complete the survey that pops up when the webinar ends. Your honest feedback will help us to make our program the best it can be. Thanks, everyone, and we hope you enjoy the rest of your day.